Renal impairment and fever. Scenario: a 22-year-old man with no significant previous history is seen in the emergency department in the evening. He reports a 4-day history of fever, aching muscles, and rigor. His temperature is 39 degrees Celsius. Urinalysis shows proteinuria and hematuria. He is admitted for observation. The following morning his creatinine on the admission sample is noted to have been 275 moles/L and you are asked to see him. The referring doctor wonders if the patient may have a systemic vasculitis because of the fever, urinary findings and renal impairment. Introduction. What do you want to know next to guide your immediate management? There are 3 key pieces of information. The state of the patient's circulation. The renal failure may be due to circulatory shock. What are his vital signs? How much urine is he passing? Acute renal failure, ARF, is usually associated with oliguria or anuria. If he is passing less than 0.5 ml/kg per hour, his creatinine is likely to be rising rapidly and renal replacement therapy may be necessary within 24 to 48 hours. If he is unwell and it is not clear that he is producing good volumes of urine, then a catheter should be inserted to enable continuous monitoring of urine output. What are today's blood results? In particular, determine serum potassium and creatinine levels. The possible causes of ARF can be usefully considered by thinking through the processes involved in renal physiology. Blood perfuses the glomeruli, generating a primary filtrate that is modified by the tubular epithelium and which then passes through the ureters, bladder, and urethra. Thus the possible causes of ARF can be categorized as follows. Prerenal disease, hypotension or reduced intravascular volume. Renovascular disease. Glomerular disease. Renal vasculitis. Tubular and interstitial disease. Post-renal obstruction, potentially in the renal pelvis, ureters, bladder, or urethra. Which possible causes of ARF are most likely in this case? The short history and prominent constitutional features in a previously fit man suggest he could have reduced renal perfusion due to a severe systemic illness. The commonest cause of renal failure in this context would be acute tubular necrosis. However, the presence of proteinuria and hematuria would not be expected in a diagnosis of ADN and raise the possibility of a renal inflammatory process, an acute glomerulonephritis, a vasculitis, or a tubulointerstitial nephritis. Another possibility to be considered is that he has unsuspected chronic renal impairment accounting for his raised creatinine and an unrelated acute illness. What would you consider a normal glomerular filtration rate for a 22-year-old man, and what do you estimate this man's glomerular filtration rate to be? A normal glomerular filtration rate, GFR, in a man of this age would be 80 to 150 ml/min. If his creatinine were stable at 275 moles/L, this would give an estimated GFR of about 25 ml/min. But his GFR could be 0 ml/min, you only have a single value of creatinine, which may be climbing rapidly. NB. Even when glomerular filtration has stopped completely, serum creatinine will rise only by about 200 moles/L per day. History of the presenting problem. Assuming the patient is not in extremis, you will clearly start to take the history along the lines of what did you first notice, but key issues to probe include the following. How long have you been unwell? When were you last completely well? He says he became unwell 4 days ago, but the point is important enough to pursue. 22-year-olds may be rather dismissive of more subtle symptoms, and patients with systemic vasculitis have usually been unwell for weeks or months. Possibility of infection: has he had contact with anyone else who has been unwell, and has he been traveling recently, which brings in a wider infective differential? Other relevant history. Ask specifically about the following. Possibility of multi-system disorder, skin rash, arthralgia, trouble with ears or sinuses, pins and needles/numbness/focal weakness, mononeuritis, and hemoptysis, suggestive of pulmonary hemorrhage. Sore throat may suggest IgA nephropathy or post-streptococcal glomerulonephritis, but both are unlikely in the scenario described. Drugs, prescribed or non-prescribed, some can trigger interstitial nephritis or, less commonly, vasculitic reactions. Examination, general features. Look for signs that the patient is very unwell. If near death, call for intensive care unit help immediately. Do not wait for cardiac arrest. Next, on a quick head-to-toe screen, look for potential sources and signs of sepsis, for signs to support a diagnosis of vasculitis, skin rash, typically palpable purpura, and splinter hemorrhages, and perform a full physical examination. Your examination reveals a temperature of 39 degrees Celsius and pulse 110/minute, regular. The patient's peripheries are strikingly warm and his BP is 90/60 mmHg. There are infarcts around his fingertips, Fig 11, and widespread muscle tenderness. What are you considering now? These findings are very worrying indeed. They would be most unusual in systemic vasculitis, as would the abrupt onset and the rigor. The picture is more suggestive of a septicemic illness. Nail fold infarcts suggest acute endocarditis, and aching and tender muscles are common in Staphylococcus aureus septicemia, which should lead you back to take further history about recent infections, trouble with boils or spots, an abscess anywhere, bad toothache, or a visit to the dentist. Following such prompts, this man recalls that he had a spot on his elbow which burst a couple of days earlier. Examination suggests an infected olecranon bursa. The possibility of staphylococcal endocarditis now leads you to repeat the cardiovascular examination. The pulse is too rapid to be sure of its character, but is there a decrescendo murmur? NB. Severe acute aortic regurgitation may not be accompanied by an obvious diastolic murmur. Making a diagnosis in a sick patient often involves taking a history, physical examination, reviewing investigations, repeating elements of the history, repeating elements of the physical examination, re-reviewing investigations, and so on repeatedly. Approach to investigation and management. Your clinical diagnosis is acute endocarditis, probably staphylococcal. You need to confirm the diagnosis, institute appropriate supportive treatment, and start empirical antibiotic treatment. Today the patient's creatinine is 400 moles/L. What do you think is the cause of the renal failure? Renal failure is likely to be mainly due to hypotension and the sepsis syndrome, but it is probable that there is also active glomerulonephritis, as indicated by the proteinuria and hematuria. Bacterial endocarditis can be associated with glomerulonephritis, similar to post-infectious glomerulonephritis histologically, acute interstitial nephritis and embolic events. Investigations. Laboratory tests from the day before show a low platelet count, a neutrophil leukocytosis and a C-reactive protein, CRP, of 300 mg/L. These are consistent with a diagnosis of septicemia. The high CRP and neutrophil leukocytosis are consistent with bacterial infection or systemic vasculitis, but the low platelet count is a typical feature of sepsis and would be uncommon in systemic vasculitis, where the platelet count is often elevated. The following investigations should be arranged. To pursue the diagnosis of bacterial endocarditis, blood cultures and an echocardiogram, which revealed aortic vegetation in this case. To assess severity and monitor for complications and progress, FBC, clotting screen, electrolytes, creatinine, liver/bone function tests and CRP, arterial blood gases, CXR, ECG. To consider vasculitic disease, antinuclear antibodies, complement levels, C3 and C4, antineutrophil cytoplasmic antibodies, ANCA. However, note that 1. The indirect immunofluorescence test for ANCA is not uncommonly positive in endocarditis and other infective conditions. The specific tests for antibodies against serum proteinase 3 and myeloperoxidase are much less likely to mislead, and 2. C3 and C4 levels are commonly low in infection-related glomerulonephritis. Management. NB. Keep the relatives informed. They need to know that this man could die. In a life-threatening situation such as this, it is often essential to start treatment before the diagnosis is confirmed. The following are appropriate here. Supportive care. Transfer him to the intensive care unit/high dependency unit and ensure he receives high-flow oxygen, urinary catheterization, and close hemodynamic monitoring. Central venous line and arterial line, ventilatory and inotropic support may also be required. Specific treatment, appropriate antimicrobials. Initially the patient must be started on broad-spectrum cover, but given the suspicion of staphylococcal disease this must include high-dose flucloxacillin or vancomycin, and consideration of valve replacement, Fig 12. NB. ARF occurs in many severe illnesses. It is crucial to consider underlying diagnoses such as sepsis at an early stage. About 1/3 of a series of 200 patients with bacterial endocarditis developed ARF, which was more common in the elderly and those with Staphylococcus aureus infection.